All right. Welcome everyone. Really looking forward to spending the next hour together. So this CIN webinar, a model for equity center quality improvement, is what we'll be discussing over the next hour. We'll spend our time together today just introducing practical strategies for incorporating equity into the model for improvement and hearing lessons learned from the California Department of Healthcare Services and Institute for Healthcare Improvement, a collaborative they are doing together, the Child Health Equity Improvement Collaborative. You'll also get to hear from two of the managed care plans that are participating in this collaborative about how they've used this model to improve well child visits. You can go to the next slide. For those of you that don't know, I want to share a little bit about the California Improvement Network. So, my name is Marie Hubbard. I lead the efforts of the California Improvement Network. You'll also hear me say CIN, and I'm sure you'll hear others say CIN as well. CIN is a learning and action community that advances equitable healthcare experiences and outcomes for Californians. And we do that through cross-sector connections, spreading good ideas, and implementing improvements. On the next slide is just you'll see a little bit about the two organizations that really fund and support the California Improvement Network. So CIN is a program of the California Healthcare Foundation, and it's managed by Health Force Center at UCSF, which is the organization that I currently sit at. And you can learn more about our organizations by visiting our website. I will put those links in the chat after we get through this intro. So on the next slide, I just want to share a little bit about CIN is really centered and is a core part of the network is on co-design. And so much of what we do is really built on hearing from feedback from all of those who participate in our activities, as well as our partner organizations that really help drive the strategy of our network. And so at the end of our hour today, there'll be 3 questions, a poll that pops up. It's super quick. I highly encourage you to fill that out. We want to make sure that the content we're providing from CIN is responsive and that we're really kind of hitting the needs of your organizations and really the needs of the healthcare ecosystem across California. And I also want to note that we'll have time for Q&A closer to the end of our time together. So as you listen, consider what questions you might have for our speakers and feel free to either put your name or the question itself into chat. And when we get to that open Q&A during the end, I'll make sure to either call on you and have you ask your question live, or I can ask the question on your behalf. So with that, I'm thrilled to get this conversation started, and I'm going to pass it over to Ashley Jackson and Jesse McCall from the Institute for Healthcare Improvement.
Thanks so much, Marie, and we will MC our session from the rest of the way here on out. I'm Jesse McCall. I'm a Senior Director and Improvement Advisor at IHI, working in close partnership with Leland, Arlene, others at DHCS on putting on this collaborative. And Ashley, I'll have you introduce yourself before I go along any further.
Hi, everyone. My name is Ashley Jackson, and I am a director at IHI. So good to be here.
Thanks so much. So before we get into talking about the structure and details of the collaborative and the great work that the two teams that are with us have done, we want to invite in our DHCS colleagues, the sponsors and funders and partners in this work, to talk about a little bit about why child health is important to them and how they've been involved in funding and sponsoring and putting this work together. So Arlene, I'll pass it to you.
Thanks so much, Jesse. Hello, everyone. Dr. Seifer and I represent the Department of Healthcare Services for today's presentation, and we will be talking about our partnership with the IHI, our Institute for Health Improvement partner, and our project with on equity-centered quality improvement. My name is Arlene Silva, and I'm a nurse consultant within DHCS Quality and Population Health Management Program, alongside with Leland, and I lead efforts on quality and health equity statewide initiatives at our branch called the Quality and Health Equity Transformation Branch. I've been here at DHCS under quality improvement for 9 years, and what we do here is near and dear to my heart. So for the next slide, please. So DHCS goals and the guiding principles within our comprehensive quality strategy, by the way, this is in our website, define our commitment to improve services and achieve high quality, equitable healthcare for our members receiving Medi-Cal. As you can see on the right side of our slide, our focus within California continues to be improving services among our members, especially children and behavioral health. Although we have made some progress, we still have a long way to go. Across the years, we have worked hard to move dents, and and we do realize this effort goes beyond DHCS and managed care plans. So we pulled in our quality improvement experts on the field, such as IHI and also the Center for Care Innovation. Together, we developed a quality improvement project that took into consideration member voices and perspectives in co-designing meaningful interventions in partnership with our managed care plans, providers, and leveraging community relationships and support. Through this project, we noted our key barriers to receiving care from the perspective of our caregivers, our providers, such as appointment availability and transportation issues. We also noted the importance of having synergized multiple approaches or interventions, such as member engagement, care access coordination, provider workflow process modification, and leveraging community partnerships, which led to more impactful outcomes. So now then I'll turn this over to Dr. Leland Sofar, the Clinical Quality and Health Equity Performance Improvement Section Chief, who will go over our goals and priorities. So turning it over to you, Leland. Thank you.
Thanks, Arlene. Yeah, great overview, well said. And I think this partnership with IHI and DCI to foster that elevation of member, provider, and community voices and perspectives and bake that into shared improvement work across the delivery system is really key to the DHCS mission and what our goals and priorities are. And really leveraging organizations that members trust through those partnerships in order to elevate and advance member-centered care. And that's core and foundational to advancing health equity. And you can see on the right side that pediatric preventive care is really a key focus for DHCS as it's reflected in 2 out of the 5 of the 50 by 2025 bold goals to close racial and ethnic disparities in well-child visits and immunizations by 50%, and to ensure that all health plans exceed the 50th percentile for all children's preventive care measures. So we see this type of collaborative as absolutely essential for building those partnerships and pulling in all the right voices to really bake in member perspectives and align with providers and community organizations and voices in order to advance equity-centered improvement work that really advances the mission. And the focus today is on this work that we've done with pediatric preventive care, but some of those principles are applicable beyond just that sort of clinical scope. So I do want to highlight that as well. We can go to the next slide and back to you, IHI colleagues.
Thanks so much, Arlene and Leland. It's been such a pleasure to work with you on putting this collaborative together, engaging our teams, and what you had said around partnership. And I think that's really a theme for the work that we've done. Partnership and alignment between the work that's ongoing and new best practices that we're trying to test and introduce. So a little bit about the structure of the collaboratives to give you a sense of the context that this work has happened in for the team presentations. And then Ashley's going to talk a little bit about the specific interventions that we led the teams through, and tools that they used and that you would have access to, should you undertake quality improvement work and want to have a specific equity focus to it. So here's the IHI team, led by our VP of the equity portfolio, Camille Burnett, our project staff, Elias and Laura, who keep us organized and in the right places, and then Ashley and I, who kind of are the co-ringleaders of all the different activity that happens to put something like this on. So keep going a little bit more about the collaborative structure itself. So this was our overarching aim, as Leland said, really aligned with the bold goals of increasing completion of well child visits for two specific age groups. We're looking at infants 0 to 15 months, as well as adolescents 15 to 18 years. And in partnerships with clinics, providers, and community-based organizations, 75% of the managed care plans in California, all of them were participating in this collaborative, and there are 23, as you may know. I think that number is right. But they will test and at least one new to them idea within each of our 5 different interventions. So trying to put what we know as learning and best practice into action at their specific locations. We did this entirely virtually through a series of biweekly calls over a year-long period. If you go to the next slide, as I was saying, 22 managed care plans. Sorry, we started with 23 and then they consolidated a bit. We work with our faculty team that includes CCI, the Center for Care Innovations, as well as a child health expert from indeed Dr. Ndidi Unaka, who's at Stanford University. She really helps us bring in the clinical best practice and expertise as well. So we, as I was saying, had a 12-month collaborative, entirely virtual, focused on 5 different interventions. So one intervention every 2 months or so during this year-long time period. And as Ashley leads us through the interventions, hopefully you'll see that they build on each other through this kind of logical process to engage members, develop solutions, test them. Each of the teams were managed care plan staff members, either in population health, engagement, outreach, whether they were specific to pediatrics or not, but usually 4 to 7 individuals at the managed care sites. And they were charged to partner with one pilot clinic, a pilot clinic that they identified through looking at data that were not meeting well child care visit goals, and that they were also able to identify specific population disparities relevant to their clinic location. So it's not that we said everyone has to work on this specific population. We wanted it to be impactful and meaningful for that clinic and the community that they were working in. So with that, I'll pass it to Ashley to lead us through our 5 different interventions and the tools we used.
Thank you, Jesse. So I will be walking us through each of the interventions that are listed here. So there are 5 total that we spent the entire collaborative really focusing the work around. And the first one was focused on equity and transparent, stratified, and actionable data. And this first intervention really focused on, it really was the foundational setting for the collaborative. And it was an opportunity that we introduced early on because it was really important that plans knew how to stratify member data by race and ethnicity. And that's what we wanted to really focus on, in addition to wanting them to identify a pilot clinic partner to work with throughout the course of the collaborative, and also identify a priority population of focus. So all teams were able to identify a pilot partner clinic to work with, and noted that they were able to stratify their data to identify the disparities to then select a priority population. So this is also the intervention block where teams determine their aim statements. And this is where they also started conducting small tests of change by implementing PDSA cycles. So an example of one of the team's aim statements was to increase the rate of well child visits for their members who identify as Hispanic and are assigned to their pilot site from 42.49% to 44.99% by March 2025. Okay, and the second intervention block, understand provider and patient caregiver experiences, we introduced two equity tools. One of them was a three-part data review, and the other one was a patient journey map. So we know that, with quantitative data, it really only provides you with a snapshot of the current state and highlights, the disparities that exist within a system, but it's only telling you a part of the system story. So to fully understand inequities and drive meaningful change, we really wanted to provide an opportunity for teams to think about how they can collect information and qualitative insights through interviews. So they were asked to interview at least three providers from the pilot clinic that they were working with. And they also were asked to interview three patients or caregivers from their priority population to understand the lived experiences and the barriers and supports to care, access, and quality. And in turn, they were asked to summarize those findings and share it out with the group. So they then created an equity journey map of the patient experience around well child visits to both highlight the pain points and identify opportunities for improvement. So ultimately, these conversations lay the foundation for high impact equity driven work that allow teams later on to co-design solutions that were really grounded in equity. Okay, and so for the next intervention 3, which focused on reliable and equitable well child visit processes. In this intervention, plans in partnership with their pilot clinic selected a focus area around access, engagement, or panel management that they wanted to improve. So this is where a lot of the PDSA testing occurred. Some of these tests included sending out text notifications from the providers that the patient needs to schedule a well visit following the following month, outreach being conducted by bilingual staff to Spanish-speaking members, and testing outreach strategies to help adolescents who are transitioning from pediatric to adults. So you'll notice that 40% of those teams were able to complete 3 PDSA cycles, but by the end of the collaborative, all teams were able to complete multiple PDSA cycles. And in intervention 4, asset mapping and community partnerships, the equity tool that we introduced during this intervention were actor maps. So an actor map is a system that provides system map that provides insight on key organizations and potential stakeholders. It really focuses more on relationships and interconnections and really helps show how parts of a system are connected. So in actor mapping, you brainstorm all types of stakeholders in a community, and then you begin to map where they are and distinguish the values, interests, and assets. So the plans met with their pilot clinic to map out local community partners related to their areas of focus and determine who they were and if there was an existing relationship, and whether or not there were opportunities for them to partner on well child visits. So they learned how to reach out to those organizations to set up those partnerships and then components of establishing those relationships. So 100% of the managed care plans were able to complete an actor map during this intervention. And the last intervention, partnering for effective education and communication. In this intervention, they worked with their pilot clinic to identify a community partner that they wanted to work with in the future And if they already had an existing relationship with the community partner, they then identified an education component that they wanted to co-develop and test with their priority population. So we really spent this time talking about how to build trust with a new partner, or how to repair trust if it has been eroded in the past. We also shared an equity and co-production toolkit that was developed by Cincinnati Children's Hospital that really maps out co-production in practice and what that actually consists of. So we also encourage teams to use a few of the assessments that were in this guidebook that is linked in this presentation that that really just allow teams to assess whether or not they were even ready to do co-production with a partner. And there was also a racial equity map assessment that was in there as well. So one of the learnings, I'll share this really quickly, when we had asked teams how this experience had shaped how they partner with communities and clinics differently, one of the teams had mentioned that that there was an honest need to begin the journey by setting down their immediate plans that they came in with and really listening with humility first. And so they were able to really hear what their population of focus truly needed by listening to the providers and listening to the community organizations that serve and interact with their shared members every day. And so they also said that, it's important to set the tone of mutually beneficial outcomes when amplifying and aligning goals, sharing stock and assets and commitment. So I will end this with advice for you all. Sorry, as you enter. My apologies. I don't know if y'all heard my dog. But as you enter in this work of implementing and incorporating equity in your quality improvement in your health equity journey, that one, look into developing your skills in applying improvement science and equity approaches to any visit. So this right here is specific to well child visits, but this is really for any area that you're working in, right? Thinking about co-creating strong partnerships that are really based on mutual goals. So it's not, a top-down approach, you as a plan coming in, just sharing your goals and expectations for the relationship, and then identifying a priority subpopulation that you want to work with to really understand what their needs and their assets are. And then mapping your MCP system and possibly partner with a community-based organization, which I'm sure a lot of plans are currently doing now. And then thinking about how you can adapt some of those proven interventions into your work. So these are a list of our, oh, I'm so sorry. I just realized I did not advance over. So this right here is just the key advice for the team success that I had shared. And then this right here is just the overall accomplishments for phase one. So these were all the things that the teams were able to do, the reach, the overall impact. And I will then pass this along to our two teams that are here to share about their experience in this work. And so the last thing I'll say is, improvement in population health outcomes we know can take a lot of time. So it's not expected that, there will be drastic outcome level changes seen after a year of this collaborative. And so in service of, the larger outcomes we hope to improve, IHI and DHCS hope to produce a variety of smaller outcomes that will lead to reduction in health disparities, improve population health. So I will now pass this along to Molina Healthcare and Blue Shield of California and Promise Health Plan, so they can now share their experience and how they've been able to apply equity-focused QI methods into their work.
James, looks like you're talking, but you are muted, my friend.
I do some of my best work while muted. Um,
Me
now,
too.
good afternoon. I'm James Kyle. I am the Senior Medical Director for Quality and Health Equity, and this is Roxana Annapolis who's with me, our Program Manager in our department. Today, we will be discussing the initiatives and strategies implemented by Molina Healthcare of California for a DHCS and IHI Child Health Equity Collaborative. Our focus is on improving healthcare outcomes in children and ensuring equitable access to quality care. So let's begin with an overview of our pilot site. Roxana?
Hello, everyone. So this is our pilot site for the collaborative. It is Clínica Médica Familiar. It is a small family medicine facility that is located in the high desert in the city of Hesperia. And it is a small team, but they house a significant portion of our membership population. And we chose them for their commitment to providing comprehensive healthcare services to the community, as well as they met the criteria for this collaborative, which was low performing clinic in our wild child visit rates and located in the Inland Empire. And as you can see there are some images of the outside of the clinic, the inside of the clinic, including the examination rooms and their waiting area. Next slide, please. So the primary goal of this project was to increase the well child visit rates at CMF Hesperia to match the 50th percentile by December 31st of 2024, with a targeted approach on serving Hispanic, Latino, and unknown ethnicity populations. So with the guidance of DHCS and IHI, we implemented interventions to try and support this goal. For intervention one, we stratified data to include race ethnicity more accurately within our data system. During intervention two, we interviewed clinic staff and members to learn about the barriers affecting WCV rates. This was probably one of the most valuable parts of the collaborative for us, as it provided firsthand insight from our members regarding the barriers that prevented them from attending these wild child visits. After intervention two, and based on those findings, we funded a family medicine physician that would offer wild child visits on the weekends. So the clinic opened Saturday clinics, which helped improve access for working parents and school-aged children. We also enhanced the clinic's EHR system by adding a patient portal for appointment requests, a pre-registration link to streamline the patient check-in, and text message reminders for appointments. Additionally, our quality team trained the clinic staff to ensure there was accurate documentation and reporting for the services that were rendered. And then intervention 4 and 5, we partnered with Reach Out and Read, which is a CBO that provides books for young children, and collaborated with our health education department to produce health education videos and brochures that are displayed in the clinic's waiting area in both English and Spanish, as this clinic has a 60% Spanish-speaking population. And we lastly launched a survey and provided some gift cards for completing the survey. And the survey basically gauged members' understanding on the importance of wild child visits. And it was meant to be completed with their primary care physician to sort of ensure that there was that connection there. Next slide.
So a large part of our success in this project was due to available funding provided by Molina Achieving Equity in Primary Care, which is our APEC program. In 2024, we funded $252,000 worth of care, covering part-time medical staff, EMR subscriptions, cervical cancer screening supplies, and reimbursement for specific agreements. In 2025, the funding is set at $121,000, including extensions for medical staff and gift cards for survey completion. Our goals include providing well child visits at least 50 Molina members per month and closing cervical cancer screening gaps for 153 eligible members. Next slide. Here, we are showing the month-over-year compliance rate for Clinica Medical Familiar for January 2024 to December of 2024. As you can see, the compliance rate has significantly increased over the months, starting at 2.51% in March of 2024 and reaching 47.69% by December. Although we did not meet our target goal of 50%, the progress is a testament to the effectiveness of the 5 interventions and the dedication of our clinic staff, Melina team, and a ton of friendly nudges across the board. Next slide.
So one of our lessons learned was that trust was essential for success. Most of our team was new to the team at Clínica Médica Familiar, and some were even new to Molina. So there wasn't really any previous relationship established or any knowledge of the work styles or accountability either part had in any work, especially not in this project. So it's definitely an uneasy feeling to highlight the low WCV rates as part of our meetings and to test all the changes and interventions and trust that everyone was going to carry through. But as this quote states, the only way to find out if you can trust somebody is to trust them. And we did just that. Our team made it an effort to have several check-ins with the clinic staff and its leadership to ensure that the team understood the commitment and milestones tied to this work. In addition, we had weekly check-ins to provide a space for the clinic to voice any concerns, questions, or just to follow up on any pending items. In the image to the right, you see greenery and flowing water, but what you don't see is the trek it took to get there. It was a partnership that definitely included a lot of pivots and challenges, but nonetheless, at the end of the road, there was something vibrant and viable that happened. And it turned out to be a wonderful partnership that not only helped our WCV rates climb, but also helped us gain a CBO partner whose mission aligns so well with ours. Next slide.
So, in conclusion, we learned a lot during this collaborative. We have seen the importance of adaptability, ongoing training on best practices, and understanding the patient's journey to make the changes that translate into effective results. Testing changes has shown us that small adjustments can lead to significant improvements. Obtaining buy-in from providers and staff and maintaining open communication are key to successful implementation and helping build trust and unity in our mission to better serve our members. We are grateful for this collaborative, enlightening areas where we could work hard hand in hand with our clinics, so much so that we are interested in expanding the approach to other clinics in our counties. We want to thank you for your attention, and we look forward to continuing our efforts to improve healthcare equity.
Thank you so much, James and Roxana. I was going to just provide a bridge over to you, Tony.
Thank you. So, hi, everyone, and thanks so much for having me today. It's great to be here to share a little bit about the work that we've been doing through the collaboration with IHI. So, for starters, I'm Tony Ratty. I'm the Quality Improvement Program Manager at Blue Shield Promise Health Plan, overseeing San Diego County. So, today I am going to go highlight 2 of the key tools that were central to our approach during this collaboration. Okay, next slide. Okay, so first we're going to go through how we use data collection and stratification, and second, how we incorporated interviews, especially with the members, into designing better interventions. So we did begin by partnering with our pilot clinic in South County, San Diego. They were able to provide us with deeper data insights and helped us identify our population of focus. And together we were able to develop a clear aim statement that both worked for us and the clinic. Okay, and then we were also able to incorporate member and provider into interviews. These conversations did help us understand the barriers both of our members and providers were facing, and then it was helpful in guiding us to select interventions that to test that could help work for this. Okay, next slide. Okay, so through data stratification, we identified a key opportunity within our membership. Our focus population was Hispanic members aged 15 to 21 at our pilot clinic. Right at the start, looking at our data, we wanted to select 15 to 18 for this collaboration, but with working with our provider, with our pilot clinic, they saw a great need with the population from 19 to 21 to add those in. So taking their advice, we did add that in as a focus population. Okay, so some things that we did accomplish during this process, we were able to identify gaps in our data, like enrollment status, housing, and rural indicators that we are now prioritizing with data stratification. And then to improve our focus, we added filters like age, gender, geography, zip codes, and clinic location. This just helped us narrow down our focus population and make sure that we're looking at the areas that there's the most need. With this information and these data elements, we actually built out Tableau dashboards with heat maps. You'll be able to see that in the next slide. That overlay with these data points and helped us visually pinpoint areas that we needed to focus on. Of course, we did have some challenges too. Incomplete data, especially around race, ethnicity, language, and social determinants of health is still limiting us. We are exploring new data sources beyond those traditional systems. So we're trying to tap into some community level data, also utilize the clinic level insights as well. And then one key takeaway from this section was just around collaboration. So we are now working more closely with our internal teams on how to with our data to improve our data analysis and stratification. And we've also developed some well-child work groups so that we can work with different departments in this sector and we can come together and collaborate. Also, with our pilot clinic and our providers, we see potential for providers to actually gather the data on their end with clinic settings and community partnerships. Okay, next slide. Okay, so here's a look at those heat maps that I mentioned earlier. So these did help us identify the zip codes with the highest impact. You can see at the bottom on the left-hand side at the bottom, those areas where the most support is needed. And these zip codes also coincide with the clinic locations as well. Again, we didn't just rely on the data alone. We did make it a point to check in with our clinic partners. The clinic partners that we did select, they have a robust data team that works hand in hand with their quality team. And so during our quality meetings, we actually had great conversations around data stratification, and their insights did help us interpret the data more effectively. And then we were able to actually identify additional data elements to look through. I just think that this first intervention did really help us build that engagement right from the start. Perfect. So now let's shift into the member interviews. So with the IHI collaboration, we actually used the learnings from our biweekly meetings and the tools provided during our member and provider interviews. And these included interview guides and the journey mapping tools to understand the members' experiences. So during this section, we did leverage our Well Child Clinic days to conduct one-on-one interviews with Hispanic members aged 15 to 21. And then to prepare for those interviews, we used the pre-selected guide, but what we made sure to do is just to keep things flexible and have the conversations flow naturally. We thought that this really did help us uncover some in-depth barriers and stories directly from the members and helped the members feel more comfortable and not just answering questions. Okay, so next slide, please. Okay, so one story for an example was a 20-year-old woman who had been living on her own since age 16. This was the first time she was actually contacted as a young adult for a health appointment. So she really opened up to us and expressed some fears that she was feeling as an adult with her healthcare. One of her biggest barriers was transportation. She had to borrow a car to attend this Well Child Clinic day. In the past, she used public transportation, but it was unreliable. And then one thing that did stand out to us was that she was unaware of our plan's transportation benefits. So this was a common theme that we're hearing directly from our members, is not knowing their Medi-Cal benefits and what their plans offer. And I think that was a key learning to take back and develop some of our interventions around that. And especially with this age group, they're just now learning to take take charge of their own healthcare, so they might need extra support navigating the system. And then thanks to this interaction, we were actually able to connect the member with some transportation support for the future visits. Also, she needed a dentist and a provider. And then she expressed some needing resources for college funding and career planning. And then the last thing I'll say about this is just, I really did connect with this section just because it's a really great reminder. Like in quality improvement, we tend to look a lot at data, but it's a great reminder just to know that there are behind the data is an actual person, and having these face-to-face interactions, hearing the members out, knowing their barriers, is an opportunity for us to create change. And then this is just a visual of the journey mapping template so that we could narrate out the member interviews. Okay, so next slide. Okay, so reflecting on the interviews and some things that we learned, just when you're having these face-to-face interviews, make sure you have a plan, but you have the ability to stay flexible with that. Use a guide, have some predefined questions, but also let the conversation flow naturally and just adapting as needed. Meeting the members where they are. So this could mean emotionally, culturally, or logistically. We thought the clinic days were a great setting for this. We were able to meet the member face to face in their community. We met them with empathy and also just made sure that the conversation, that they were feeling heard, and it wasn't just like answering questions. Also, the third thing is that we were able to expand our one-on-one interactions. So what did start as individual interviews has evolved into focus groups. We're hoping that that can just give us some deeper insights with our Medi-Cal members. Okay, so next slide. Okay, so this is the last slide that I have here today. I just wanted to go into what's next for us. So we're building on what we've learned from IHI and this collaboration. And so we are, again, conducting those focus groups to gather some data, some feedback to tailor our interventions further. And then we're also expanding partnerships with community-based organizations and providers to improve access to care. This is especially through those dedicated well-child clinic days. And then we're preparing a pilot mobile unit program with this selected clinic. So we're hoping that this can bring care directly to members, removing some of those barriers and meeting them where they're at in the community. So we heard over and over transportation is a huge barrier. So hopefully bringing the mobile unit to an area can mitigate some of those transportation. And that was from the members directly, but even from the selected clinic, transportation is a huge topic with them, and trying to work with them on some process improvements there. Okay, so we're just so excited to keep moving forward with this work and our collaboration, and just want to thank you for having me here today.
Thank you so much, Tony. And again, thanks, James and Roxana. Just, I think, excellent examples of this equitable approach and attention to data stratification, directly engaging with people to understand barriers, co-developing solutions to those barriers, and trying to learn and engage with members through different avenues in your system, whether that is directly or through community-based organizations. So just thank you for trusting and following along with the process that we laid out, and congrats on the results that you did achieve so far. We have a couple of questions that did come in the chat. Our first one comes from Yen, and I'm not sure which of us wants to address this, but Yen is writing, studies have indicated that child health depends largely on the parents. For example, the major barrier to bringing children in for the clinic has a lot to do with the parent schedule, of course. Because our approach has been kind of multifaceted, looking at the independent impact of that additional clinic day, that, being open on a Saturday, were you able to look at that as kind of an independent variable, or if not, how much of a contributor to your improvements is that extra day versus other strategies you may have tried?
Well, I'll take a stab at that. We were clear that the weekday appointments were problematic for parents because their children were in school and trying to find an opportunity to get their child to clinic. The Saturday clinic opened up a real opportunity for parents to bring their children in, especially when maybe only one child needed an appointment, but they had two or three, and so the other three had to come along with them. So coming in on a weekend day was much easier than coming in on a weekday. So we think it made a dramatic difference at after what we call after hours care, either evenings or weekends.
Please, Roxana, add to that.
Yes, and to add to that, I do see something around what, like, how we decided on Saturdays versus extending evening hours. So that the evening hour option was definitely on the table, on the drawing board. It was just easier for the clinic at the time to kind of open up a new schedule. We welcomed a new family medicine provider that could offer these slots that, as Dr. Kyle mentioned, parents are looking for just whatever is convenient for them and their children. Their kids are going to school, they're working. So it's a little bit easier, from what we talked about as a team between the plan and the clinic, it was a little bit easier to open up those Saturday slots. And thinking that parents are coming off of work, probably heading to make dinner for their children after school activities. So in our minds, it made a little bit of sense that they probably might have a bit more free time during the weekend on that Saturday to come in as opposed to extending those evening hours.
I also wanted to second everything that you both were saying about the Saturday clinics, because we have had them throughout the year and have noticed like a huge amount of members showing up. And that was one of our, during our patient interviews, that was one of our challenges, parents not being able to take their kids to their appointments. And we saw a huge uptick in those members coming to our Saturday clinics. And this year we're actually trying to pilot the after hours clinics. So hopefully I can give you more information on how that impacts our member rates and members showing up versus the Saturday clinics.
Thanks so much to you all for the, I think, comprehensive response. And I hope that was helpful to you, Yen. Thanks for the great question. Our next one comes from Teresa, and I think poignant given that we started all this with a need to look at stratified data. So Teresa is wondering how have folks navigated an increase in hesitancy to provide identifying information in kind of our current climate? What are some considerations for how to continue identify and track disparities if the data aren't as accurate around SOGI or real information that we're gathering?
Roxanne, you want to take a stab at that?
So to be truthful, I think we've had a lot of um, issues gathering this data in general. As you mentioned, with the political climate as it is, it's probably getting worse. So we definitely have challenges around that. And what has really helped us was talking to the clinic. I think we've just had that line of communication with them where we can interchange the information that we have with theirs. So that has been helpful. But to be truthful, this is some of the data that we've struggled to get. I've looked at data for a different collaborative, and it's just so limited. So definitely a piece that needs some work and, and more attention.
Thanks so much. And I can say that a common challenge across teams in this collaborative, outside of it, getting accurate, stratifiable data continues to be a challenge. Yet we know it's important, so we persevere.
It's also, we're now at a point where it's actually dangerous for some of our members to give that data because they're afraid that the data will be shared with ICE. In fact, we've had some patients actually say that they're afraid that our data is going to ICE, and we have to assure them that that's not the case. But then even to physically show up puts you at some jeopardy. So this is a new challenge for healthcare all across the country now. And we're very concerned about it because we think that there are whole swatches of our populations that are it's going to be COVID-like. They're not going to get the care they need because they're afraid to get that care, and it's a tragedy.
I agree, James.
I just want to take a moment to say thanks, everyone. This has been really informative and appreciate the conversation. I actually wanted to ask a question of James and Roxana and then Tony as well. I know that Ashley had shared a bit about the advice that from the team success from across the collaborative. But I'd really love to hear from you all, James, Roxana, and Tony. Like, what is some advice that you have for others on the call that they could take? Either they're doing this similar work, trying to improve their well child visits, or maybe they're trying to do other kind of QI work. What's some takeaways that you have or advice that you have, things you might want to do, you would have done differently if you could start over that you could share with those on the call with us?
Well, I think the first piece of advice I would give is stay humble. Don't walk into these collaboratives assuming that you know it all, because your collaborative partners have a lot to teach you. And we learned some lessons, and we also were able to give some lessons. So we mutually shared information and knowledge. One of the things that we could bring to the clinic is our perspective on multiple providers and what we've learned from those providers. And they could tell us really more about what's going on with their patients, what they know is going to work or not work with their patients. So I think staying humble is important. Staying adaptable is clearly important, and flexible. And I think having a belief that we actually can make a difference, even though in the early stages of the collaborative, it wasn't looking that good for us. We were a little concerned, is this going to work? We just buckled down and said, we're just going to follow this process and let it work for us or not. And it actually did work for us.
Yeah, go for it, Roxana.
Thank you. I think one other thing that we learned, and I know it sounds very, very cliche, very common, but just that open line of communication with the clinic was so, so helpful. I cannot tell you how many times, during our weekly calls, we were able to hash out some of the things that we had been sort of, friendly nudging for, or, vice versa. I say that for both ends, especially with this team being so small. And they also got hit with like a wave of like flu where like most of their you know, clinic staff was out. So that tiny 30 minutes that we plugged into the calendar really, really helped. And I think another thing that we don't realize is you have to take a little bit of time to sit down and talk with folks and see what is working and what's not working. I think in the daily grind every day, what you're doing, you're just kind of like, at some point going through the motions. We know we walk the patient in, get them out. And so there's no time to sit down and reflect, is what we're doing really working? Or can we improve it in any way? And some of the things that we did were so tiny, but they made such a big difference. I can't remember off the top of my head very well, but I know I have the number somewhere. But just in our Saturday clinics in a couple of months, there were like 80 something gaps that we were able to close for wild child visits and cervical cancer screening. So it definitely makes a difference. It just does take a little bit of time to just sit down and sort of craft these interventions or these small changes.
Thank
Wow,
you.
that was great answers. You guys took some of the things that I was thinking as well, especially with working with your pilot clinic. I just really do think that the collaboration needs to be there. James, I loved what you said about we don't know everything, they don't know everything. We need to work together to do the work. And so I know that in the beginning it was we had already had an engaging relationship with our pilot clinic, but we also knew that they had a huge population with us, and their bandwidth was really difficult. So we needed to work together to make sure that we could establish those those monthly meetings, meeting them more frequently and having the communication with them. And then I just, one thing that I did like with our pilot thing and would repeat is that continuing with the member interviews and also being able to interview some more provider interviews. I thought that was a challenge that we had during this section, is trying to sit down with the providers and get their interviews and their barriers. So I think that that's something that I would have wanted to go back to and have more time to do. And I think just it's a lot around collaborating and making sure that you're adaptable with your members and with the provider clinics.
Great, thank you. Really appreciate that. We have about 4 minutes left. I'm going to challenge us to get in another question because we have a few in the chat. So just want to go to Janet's question here about addressing the challenges of the first well-child visit within the first 5 days of birth. Just want to hear if anyone has any of our Tony, Roxana, James have any strategies for connecting and scheduling OB patients within that time, or if that came up at all in the work that you did with this collaborative.
So for us here, so our focus was on the 15 to 21, so that didn't come up in this collaboration. But one thing, since this is a challenging part of those first visits for the W30, we're trying to identify those members who are born and start outreach with the prenatal population, and as soon as the like we call it like our live birth reports. And as soon as we know when a baby's born, we're trying to start the outreach starting then and making sure that they're getting in for that first visit.
Thank you, Tony.
Yeah, I would add that I'm not sure we learned a lot about that particular challenge. It's hard to know when your patients are all over the county delivering. Finding out that they actually have delivered within the first 5 days is the biggest challenge. And we're trying to figure out how to overcome that. I've actually suggested that we might want to put a bounty out, a reward system, so people actually are rewarded for telling us that they just delivered. But we're trying to figure out the best way to do that, because we're finding out generally later in the first trimester that the birth has even happened. And so we missed that opening window of those first 5 days. And so we're trying to figure out better ways to catch these patients. We believe that the doula benefit could potentially help, because the doulas could help us stay informed about the deliveries. And so that's a conversation I'm about to have in about 2 minutes with some of our doulas, is how do we make that work?
Well, thank you so much, James, for jumping in for Melina. And I just want to take a moment to say thank you, everybody. A big shout out to Arlene and Leland from DHCS for being with us. Thank you so much, Jesse and Ashley, for sharing, and of course, for walking us through this last hour. James, Roxana, thank you so much from Molina Healthcare. And Tony, thank you so much from Blue Shield California Promise. We had a big group today. I was shocked we made it through, and just really grateful for all of the knowledge that was shared here today. Thanks for joining us, and thank you so much to our speakers. We look forward to seeing you on the next CIN webinar. Thanks, everybody.
Thank you. Bye.
Bye-bye. Take care.